The guest on this podcast episode has no disclosures to declare.
Hello, and welcome to the Journal of Clinical Oncology podcast, where we sit down with authors from some of the latest articles published in the Journal of Clinical Oncology. I am your host, Dr. Davide Soldato, medical oncologist at Ospedale San Martino in Genoa, Italy. Today, we are joined by JCO author Dr. Vedang Murthy, professor and radiation oncologist at Tata Memorial Centre in Mumbai, India. Today, we will be discussing the article titled Bladder Adjuvant Radiotherapy, BART, Phase 3 Multicenter Randomized Controlled Trial of Adjuvant Radiotherapy or Observation for Postcystectomy Muscle-Invasive Bladder Cancer. Thank you for speaking with us.
Thank you so much. Pleasure to be here.
So I just wanted to start a little bit from the rationale. So why did you design this trial? So we are speaking about muscle-invasive bladder cancer, and we know that usually this type of cancer is managed by neoadjuvant chemotherapy, followed by cystectomy with lymphadenectomy. So this is the usual course of treatment for patients who can receive neoadjuvant cisplatin-based chemotherapy. What was the clinical problems that you were trying to solve when you designed the BART trial?
One of the things is this was not only muscle invasive, this was muscle invasive advanced bladder cancer. And if you look at the outcomes of these patients, despite the best that we can offer them by today's standards, including neoadjuvant or adjuvant systemic therapy, including the best surgery, etc., a lot of the patients, up to 40%, would succumb to their disease even in about 2 to 3 years. So this disease needs a lot of work from our community. One of the problems with advanced bladder cancer is they do get a lot of systemic distant relapses, which I also agree. But what is underappreciated is the loco-regional relapses are a problem. Often they are underdiagnosed and underappreciated in practice. Unfortunately, when it happens, it can be quite morbid for the patient. And as you would agree, a local problem needs a local solution. And that is why we designed this study of adjuvant radiotherapy.
Thank you very much. That was very clear. So, as you mentioned, this was really a population of patients with advanced muscle-invasive bladder cancer. So, just to understand a little bit better, can you guide us a little bit through the inclusion criteria? So what was the characteristics of the patient included in the trial? Was a very advanced local disease? Did you include patients with positive lymph nodes? And then a little bit, what was the randomization and the stratification factor for the trial?
As I said, these were locally advanced bladder cancer. So they had clinical or pathological T3 or T4. They could have clinical or pathological N+. They could be margin positive, resection margin positive. One of the other inclusion criteria was lymph node dissection less than 10. That was one of the criteria that came up from the UPenn data. So if nodes are not dissected, they are at a higher risk of loco-regional relapse. And lymphovascular invasion positivity. That is something that came from our own data. So these patients are at a very high risk of developing a loco-regional relapse. And by very high risk, I mean somewhere between 25 to 30% will have a loco-regional relapse. They were randomized to standard arm, which is doing nothing. And I would remind the listeners of this podcast that at the time when this was designed in 2015 and we launched in 2016, 10 years back actually, adjuvant or neoadjuvant immunotherapy was nowhere in the picture in bladder cancer. So they would get chemotherapy, either neoadjuvant or adjuvant, and they are observed. The test arm was adjuvant radiation. This was 50.4 gray in 28 fractions, which we treated the pelvic nodes and the cystectomy bed. There were two stratification factors, which we thought were prognostically important. One is whether they had lymph nodes present or not, pathological node positivity or not, and what kind of chemo they had, neoadjuvant or adjuvant. And the primary endpoint was a 2-year loco-regional failure-free survival.
Thanks so much. And looking at the results of the trial, you really included a very high-risk population because more than 75% of patients had either clinical or pathological T3 or T4 cancer, 33% of the patient had positive disease, and basically all of the patients that were included in the trial received either neoadjuvant or adjuvant chemotherapy. So this was really a very high-risk population. You talked a little bit about what was the dosage of radiotherapy, the number of sessions of radiotherapy, but just wanted to give us a little bit of perspective on how difficult it is to provide adjuvant radiotherapy in this specific population, because here we are speaking about patients who have been subjected to surgery for their bladder cancer. So I imagine that there were a lot of struggle and a lot of technical things that could be encompassed in the protocol to ensure that this was a very safe and at the same time effective regimen.
Absolutely right. Believe me, when we started this, I was quite worried, as worried as you sound right now. How will we treat a post-cystectomy bed with radiation? There is a lot of bowel lying there, and that's a concern that we radiation oncologists often have about the bowel. But I took strength from the data from Egypt, a lot of data, including randomized data, including using 3D CRT and IMRT, and also the constraints that were originally designed from the NRG GU001 trial. We started this carefully. We included the cystectomy bed. There was initially debate whether the bed should be included or not, and this was based on the UPenn data that said that bed should only be included in margin positive patients. And I'm glad in a way that we included the cystectomy bed, because since then, our own data and some other data has shown that regardless of margin, cystectomy bed is still at risk. So we did include the bed, and that increased the chances of possible side effects. But as we went along and using very strict IMRT constraints, we avoided the stoma, we avoided the ileal conduit, we avoided the bowel as much as possible. We got more and more confidence that, look, it is not that difficult for the patients or for the planning team. Finally, it is 50.4 gray. We've been doing it for several post-operative sites in the pelvis for decades now. So it got easier with time. But I think IMRT is crucial. I would not want to do it with 3D conformal treatment. And again, I'm glad we did that. We also included the common iliac region. So we were wondering whether to go higher up or not because of the side effects. But the data shows that almost 20% of the patients will relapse in the common iliac region. So we didn't want to miss that. So we included that as well. And the proof of the pudding was in seeing the side effects. The acute side effects, grade 2, was about 17 to 20%, which is very, very reasonable given what we've done.
So this was not the main focus of this presentation, but you already reported this, and the grade 3 events that could be associated with radiotherapy were really not that different between the observation and radiotherapy arm. So going directly to what was the primary endpoint of the study, as you mentioned, it was locoregional recurrence-free survival. So just wanted you to guide us through the results, whether these were positive or not, and what do you think is the clinical applicability of the message that we get from the BART trial as of now?
The primary endpoint of 2-year LRFS was both statistically and clinically significantly better with adjuvant radiotherapy. This was after a median follow-up of 7 months. It was 76 versus 87%. So that was very good to see. That was done by an intention to treat analysis.
So as you were saying, this was really a positive study because the primary endpoint was the local regional recurrence-free survival at 2 years, and the study was positive. And this is also clinically significant because one thing that you mentioned in the study was that really all of the patients who developed a local regional recurrence in the observation arm, they could not be amended by surgical treatment. So really, I think that adjuvant radiotherapy can add something here. And I think that you were also very good when you designed the trial because you included a lot of secondary outcomes. So disease-free survival, bladder cancer-specific survival, overall survival. So I think that these are very important because they complement the data. So this was an adjuvant radiotherapy trial. So I agree that the primary endpoint should be the local regional failure, but just wanted you to guide us a little bit through these secondary endpoints and what was the results.
Yeah, before I do that, I'd like to highlight a particular statistic in the paper that may have been missed in many of the presentations, and I'd like to highlight this to our listeners. You know, the median survival after disease recurrence in the entire cohort was only 7 months. Remember, we have not given immunotherapy. Now, a lot of immunotherapy is not available to a lot of patients in the world. So, assuming that there is no immunotherapy, the median survival was 7 months. But the surprising thing, even for me, was that this was similar for patients who had a locoregional relapse or who had a distant metastasis. Both of it was 6.5 to 7 months. So, those who get a locoregional relapse also have a shorter median survival. So that is why I think it is important to prevent the locoregional relapses. Regarding the secondary endpoints, we had three important ones: disease-free survival, bladder cancer specific survival, and overall survival. And as you will see in the paper, these were approximately 12 to 15% improved with adjuvant radiotherapy, from 72 to 58 to 71%. Even the overall survival was improved from 57.4 to 70.4 months. So you see, in 2 years, the overall survival in the standard arm is 57%, which is what I was saying, that almost 40% will succumb because either of the disease, of the treatment, or of other causes. So this improvement in 12 or 13% improvement in OS did not reach statistical significance, and that probably is because of we may have fallen short of the sample size just a little bit.
But still, I think that it's very important to see what are the outcomes of these patients and also to have data from the pre-immunotherapy era. Now, what I think is very important for the listeners is how are we going to place the data from the BART trial in the context of our clinical practice right now? So do you see all patients who have these specific characteristics, so a very high risk of recurrence, receiving adjuvant radiotherapy, even if we are not considering immunotherapy in the picture as we have right now?
No question in my mind. If immunotherapy is not being considered adjuvant or neoadjuvant, which is a lot in the world today, I would definitely recommend adjuvant radiotherapy. That, in my mind, is not a question at all. What you ask about how we will place it with immunotherapy, I wish I knew the answer. I really don't. This is a field that is evolving very rapidly. Even immunotherapy is evolving very rapidly. So I do not have a clear answer on that. One of the things I believe is that the side effects of radiation and those of immunotherapy are non-overlapping. They act in different ways. They act on different parts of the disease. One acts on the microscopic disease and hopefully reduces distant metastasis. The other one is for locoregional control. We do not have clear data on the locoregional relapses in the immunotherapy era. I am looking at trials for that data. I have not come across anything very clear in that aspect. If some of the listeners or some of the experts who are listening have any indication, please feel free to get in touch with me and we can discuss this further. But I would recommend adding adjuvant radiotherapy somewhere along the way, either after surgery, before the immunotherapy starts, or once the immunotherapy starts, continue along with it, give a break. I don't know, but I think I would strongly recommend it, certainly in the absence of IO.
I absolutely agree, because I think that the benefit that we see, even in locoregional free survival, which is something that it's important because, as you mentioned, first, lots of the recurrences were not amendable by surgery, and this can also cause morbidity for the patients. And second, as you were mentioning, we see a lot of recurrence in the lymph nodes, and also these were significantly reduced with the use of adjuvant radiotherapy. I totally agree with you when you're saying if you don't have immunotherapy, absolutely, I think that we should consider adjuvant radiotherapy in this setting. But I also think that as the field is evolving, and now we are speaking about adjuvant immunotherapy, but now we have the data published for neoadjuvant or perioperative enfortumab vedotin and pembrolizumab. And I think that as the field is evolving, we will still have some patients who will be at risk for locoregional relapse. So I really think that we should move from the BART trial data to design trials that encompass both the best that we have in terms of locoregional control and also in terms of systemic control. So really trying to merge these two aspects. And one final thing that I wanted to ask you is, We know right now that in bladder cancer, there are some biomarkers that we are starting to use, for example, circulating tumor DNA. Do you think that these also could help stratify patients regarding of the benefit that they could have from radiotherapy? Or do you feel that this is mostly related to the risk of distant failure?
I wish I knew. Obviously, UTDNA is probably not relevant here. This is a postcystectomy. ctDNA, whether that indicates disease in the pelvis or disease outside the pelvis, probably no one knows. As the data evolves, we will know. And again, really, ctDNA has not come into routine clinical practice, and I don't see that happening around the world for many years. So till then, one thing I would like to highlight for the listeners, just like me, I was worried. I'm sure many of you would be worried about treating the cystectomy bed and the bowel there with radiation. But I think IMRT makes a huge difference. As you have seen with every other site in the body, it has enabled us to treat these patients safely. 20% grade 2 bowel side effects are probably a reasonable price to pay for the benefit that you get. And we'll make a start, and I'm sure you'll see that it is quite safe, like we have shown in the trial.
Thank you so much. So this brings us to the end of the episode. I would like to thank again Dr. Vedang Murthy for being with us today and providing so much insight on this topic.
Thank you. It's an absolute pleasure to be here, and thank you for having me, JCO.
So we appreciate you sharing more on your JCO article titled Bladder Adjuvant Radiotherapy, BART, Phase 3 Multicenter Randomized Control Trial of Adjuvant Radiotherapy or Observation for Postcystectomy Muscle-Invasive Bladder Cancer. If you enjoy our show, please leave us a rating and review, and be sure to come back for another episode. You can find all ASCO shows at asco.org/podcast.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.